Hello, it's Dr. Debra Durst, and I want to welcome you to the channel. If you are a return viewer, then I want to thank you. And if you're new to the channel, then I hope you enjoy the wellness and sexual wellness topics that we discuss here. Little history about me is I'm a double board certified physician, did ER medicine for greater than 20 years, and now I have a wellness and regenerative medicine practice. If you're on a journey to having better overall comprehensive wellness, and maybe even in non-traditional ways, then this is the right podcast for you. So please like and subscribe and enjoy the videos. Welcome to the podcast with me, your host, Dr. Debra Durst, and one of my favorite guests, Dr. Ibrahim, is back with me today, and you guys love him as well. So say hello, George, Dr. Ibrahim.
You're too kind, Dr. Durst. Always a pleasure being on the podcast with you and seeing you. I cannot wait to see you again in person.
I know we're going to do another one in person for sure. So Dr. Ibrahim is a urologist and Duke trained, and he has, been a professor of urology and specialized in prostate cancer. So obviously we want to go into this subject because now he does sexual wellness and hormones. And so we run into testosterone and men, and then the myths around testosterone and prostate cancer. But really today we're going to talk about prostate cancer and the risk of ED with treatment. And, we're just going to go through all some different items and summary of prostate cancer and how we address it. If you want to go ahead and start, such a common topic, right? Because I feel like all men will die with it, but maybe not die from it. Is that a fair statement?
That's a fair statement. The vast majority of men die with it, but nothing takes the place of the fact that it is the second leading cause of death by cancer, second only to lung cancer.
Mm-hmm.
So just because a lot of men die with it, I'm sorry, what about the second leading cause of death by cancer being prostate cancer?
Mm-hmm.
So cannot be neglected just because a lot of men die with it.
Correct. That slow growing, we can't default to that because it kills a lot of men. And so
it kills the second number of men in cancer world, only after lung cancer.
Well, and it's bizarre because, again, all the screening, and the anti-screeners, and then what happens, we have no standardization for screening, and then we get more advanced, diagnoses when we actually pick it up. And so, yeah, we need to talk about that myth. How can we screen, and kind of at least strategize how we're treating, who we're treating, and, and how we approach that, so that at least I think patients go down a rabbit hole. Men and their families go down a rabbit hole trying to figure out what's best for them when their PSA is up and they're approaching a biopsy.
Well, let's get back before the biopsy. One of my new physicians, Dr. Taylor Love, is recently out of residency, and I'm hearing some of the current thinkings of many primary care.
I can't wait.
And they are, the amount of neglect towards PSA and prostate cancer screening that they are being taught is just it almost makes me want to throw up. I've got something from the National Cancer Institute, and I think you're going to post this link on your site.
We will.
But everybody knows how significant breast cancer is, correct? I mean,
yes.
would that be a fair statement?
Yes.
I mean, football games, everybody's running around with pink shoes. The end zone is colored in pink. I mean, woman doesn't get out of an abnormal exam without a biopsy being done and things taking place. But prostate, they just totally ignore. This is from the National Cancer Institute. If you print out, because the way their pages are arranged, they're all identically arranged. And if you print out prostate cancer and breast cancer and hold them up to each other, let me tell you what it says.
Oh, I can't wait to hear this. I didn't look at the comparison.
At a glance, number of new cases in 2023 of prostate cancer, 288,000. I'm rounding a little bit. Cancer, 297,000. Percentage of all new cancer cases, Prostate cancer, 15%. Breast cancer, 15%. Estimated deaths in 2023 from prostate cancer, 34,700. Breast cancer, 43,000. Percentage of cancer deaths, prostate cancer, 6. Breast cancer, 7. Close so far, right?
Mm-hmm.
New cases per 100,000 people. Prostate cancer, 113 per 100,000. Breast, 127. That is a 19% for men or prostate cancer, a 20% for breast cancer, 19 and 20. Yeah. Approximate risk, 13%, 13%. They're the same numbers. Yet nobody would let a breast cancer, anything suspicious leave the office without something being done. Then we're telling men don't worry about it, or the risk of a PSA is too great, or it leads to wrongful interactions. I mean, I'm sorry, it's the same thing. So if you care about breast cancer, then your care should be the exact same thing about prostate cancer, because they're the same numbers.
I wonder if this, and just thinking through it, if this isn't again, that risk of side effects related to surgery. And historically, that's changed over time. But I wonder if that hasn't been made to be a big deal and therefore they minimize screening. Why do you think this is that we're approaching it differently?
Why they do it, I can't tell you, because I'm on the other side because I don't,
Yes.
I mean, I'm looking for prostate cancer. Dead men don't have sex, and dead men don't mind if they're incontinent, but they're dead. I mean, when it's the second leading cause of death by cancer, I think the patient has the right, or it deserves to know. I
All
think
the
the
facts.
physician is being negligent, excuse me, in not providing this information. Let the patient decide, and then we can talk about the types of different treatments and what the side effects really, are, and then what the treatments are. Because I mean, I'm going to skip ahead a little bit.
No.
So when I was chief of urology, I was in a facility that it didn't matter if I did the surgery or did not do the surgery. I was not financially rewarded either way. So, I had a very unbiased opinion when I would come to counsel patients. And if you have a young guy and I can show him the type of the worst erection that he would ever have if he needed intervention after surgery, that was better than any erection he's had in the last 10 years. These guys, they were thrilled. Yet people don't realize there are treatments for all of these problems that some people think, they shouldn't undergo prostate cancer screening, much less treatment, because they're going to end up, impotent or incontinent. And I can show them how to fix both of those.
When you looked at those numbers, and I haven't compared the two side by side, did it show that the screening for breast cancer actually decreased survival? Because I heard that, and again, I haven't looked at the numbers in depth, that the decrease in, or like the increase in survival for prostate and cancer screening is more clinically impactful than the screening with breast cancer. I could be wrong, but I'm pretty certain that it makes a bigger difference with prostate cancer when it comes to survival, changing survival.
It's to pick up prostate cancer in a younger, this would always bother me too. I'd get the consult on the 82-year-old with the elevated PSA. I'm like, he's 82. He's going to have a stroke and his heart attack before his prostate cancer. He's lived to 82. Worry about the guy who's 42. So that's where the impact comes on the physicians that are providers that are utilizing PSA as a tool. PSA is not a great test, and we'll get into that later, but make a note of that. But PSA is all we have, that and a rectal exam. And the sooner you pick it up, the better off the patient's survivability is.
And your PSA cutoff for a younger patient is different as well. So it's age dependent.
Well, and this is where it gets a little tricky, because I'm, as a fellowship trained prostate cancer person, I'm way more sensitive to PSA. I look at what's called a PSA velocity, and that's not something that I would expect out of most primary care providers. But if you're like, urologist that did the fellowship in prostate cancer, I want to see how it goes up over time. And if I see, I don't care how low the number is to begin with. If it's 0.7, and the next time I see a patient, it's 1.2, and the next time I see him, it's 1.9, I'm going, it's time for you to go get a biopsy. That's well below the number 4, which is the current number that most people get concerned about.
And it's that slow increase, not the sudden rise and the variations, but it's slowly creeping up is more concerning. So when you're talking about velocity, explain the difference between that and a percent free, or is that something you look at both of them?
No,
Okay.
so percent free that's way more complicated than I think this podcast is for. That's more of when cancer is suspected and on the biopsy, and that's not something for
Primary care.
regular providers to follow.
So then when you're talking about velocity and, rate of change, what kind of, like grossly, what kind of change is concerning?
If I see an absolute rise of over 1.0 in 12 months, then that person's bought a biopsy.
Okay, gotcha. And there's no PSA, and this brings us to the point, there's no PSA level that, predicts no cancer. That's why it's not an absolute. And again, it depends on the age, the size of the prostate, what they've been doing. And so you're saying the slow rise over time is concerning, and then above an absolute of 1 over a year for sure, they need a biopsy.
Yeah, absolutely.
Okay. And in less percent, really if primary cares just did that. And so when we're talking about screening, there's no standardization of screening currently. Isn't that correct?
That makes it difficult. I mean, as it is currently, most labs report anything over 4 as high. And in my world, to me, you buy a biopsy if you have an abnormal rectal exam, or you have a biopsy. I mean, you have a PSA over 4. That's an absolute. I mean, insurance covers that. And then, if you want to get more specific, like the way I look at it, I'm looking at the rise of PSA over time. So, I'm the guy that sends somebody to get biopsied when they're 2.7 because they started with me at 1.5.
And if they're not doing regular rectal exams, again, urology, yes, they're going to pick up an abnormal. And I did lots of rectal exams in the ER, but do I feel competent in saying that's abnormal or that's not? No.
So digital rectal exams are falling out of favor, apparently, and I cannot stress how important they are. There are so many prostate cancers that don't have any suspicion based on PSA, which I told you was a crappy test, but you can feel a nodule. So, 20% of all cancers that, at least back when I was practicing urology, were not picked up because of PSA abnormalities, but because of digital rectal exam abnormalities. A digital rectal exam, I mean, they're doing it to screen for colon cancer. Why can't they feel the prostate?
Yeah. Well, but then when they're doing it for colon cancer, they're looking for blood too. And so who knows?
Yeah. But I mean, they got a finger up there. They might as well feel the prostate.
Correct. Oh, well, correct. And do they really get good at feeling the prostate and feeling something abnormal? So, and again, I did a lot of them in the ER. I don't know that I would feel confident in saying there wasn't a nodule there, but you're saying that occasionally you'll pick one up and everything else looked good. So makes sense. And then, so basically the incidence is high. It's the second leading cause of cancer deaths in men, second to lung cancer. It's very common. A lot of men will have it, but we need to screen because early diagnosis and treatment is key because it saves lives. So when we're talking about, like we already talked about PSA and digital exams. So we talked about the diagnosis really. And so when we're talking about, because historically, let's talk about how it's treated once it's, so basically if you have something abnormal, you're referred to urology, digital rectal, that absolute increase, over a year. When they go to urology, the next step is always a biopsy if it's concerning to the urologist. And you guys look for something maybe slightly different, or maybe the PSA is different once they get there. But a biopsy really just has minor
A
issues,
biopsy
if
is a
anything.
pinprick. I
Yes.
mean, is it the greatest thing to go through? Not necessarily, but I mean, are you fine 2 seconds after it's done? Absolutely. It's just it's like a swarm of bees up your butt.
Yeah. And it's probably,
Once they're gone, they're done.
yeah. Yeah. Once
I
they're
mean,
there, yeah,
yeah,
they're out. And actually
yeah,
faster because the swarm of bees probably
yeah.
isn't going to leave anytime
Listen,
soon.
never haven't had a mammogram. From what I've heard, it sounds like a mammogram is more uncomfortable for a woman than it is for a guy to get a prostate biopsy.
Yeah, and there's nothing in the way of complications with that. And so then you have a tissue diagnosis, yes or no, maybe. But if it's negative, there's a false negativity with biopsies. Approximately what percent?
Very few, because today they're doing at least 12 cores.
Gotcha.
Prostate is about the size of a walnut. If you're 70 years old, 65 years old, and that biopsy core misses a prostate cancer, that cancer is so small that the chance that you're going to die from it before you're 82 from your heart attack or your stroke, probably insignificant. In other words, it is really uncommon nowadays. It was different back in the old days when we didn't have good imaging, but today they've got great imaging that goes along with the biopsy. They're doing multiple cores. It's rare as hen's teeth to have a false negative.
And most of the time they do it with imaging now, right?
Yes,
Ultrasound
absolutely.
or maybe MRI
MRI or
guided.
ultrasound.
Okay. And then, so 12 core means they're getting 12 different, biopsy areas. And so, very common to make the diagnosis. And then they kind of look at it and then what kind of scoring, there's Gleason, there's like, further testing with imaging, but, it scores it a little bit, put you at high risk or low risk or aggressive, and maybe just a little bit of that. Is
And
that
so
hard to
this
do?
is where the age of the patient, how many expected more years of life they have, then the grade of the cancer. So if you have a low grade cancer and a relatively older person who's got other comorbidities like diabetes or COPD, then that's the person you're probably going to say, this is probably not something to worry about. You're going to be one of those many guys that dies with it, not because of it.
Okay.
If it's a young guy with a high grade cancer, then that's a whole other story. That's the one that you're going to say, yeah, you really need to think about treating this.
All right, so they're going to give you guidance after, they do an assessment and get a biopsy back. And so then when it comes to treatment, I know historically I listened to a few things. And obviously, way back, it was a difficult procedure because, it was different and there was a lot of bleeding and all of that. But now it is, again, a very, not only effective, but like there's such advancement in surgery or the different treatment options. So can we just touch on the different treatment options that we have? Because obviously ED after treatment is a common, question and concern that we hear. So I think if we
Well,
can address
I'm
that.
going to skip to the end and then start at the beginning. ED is possible with radiation. It's possible with surgery. Watchful waiting to me is not a treatment, so I don't even talk about that. Watchful waiting is where they tell somebody, oh, we'll just follow your PSA. Well, I told you PSA is a crappy test. It is not diagnostic. Following a PSA doesn't tell you whether or not the cancer is progressing. So I don't look at watchful waiting as a treatment option. I mean, if you want to watch for wait because you're 82 years old and got COPD and other risk factors, fine, that's different. But if you're going to treat, then your options are surgery and radiation. The side effects or the risk factors, they're the same thing. The risk factors are both going to be erectile dysfunction, and then there's going to be incontinence. Now, the difference, and again, I'm biased because I'm a surgeon, but radiation has radiation cystitis, which is where the bladder is hit with the radiation beams. And that's a very irritative possibility that can happen, where patients just have this excruciating type of pain from the base of their bladder. And that's not a risk with surgery. But ED and incontinence are both risks and both totally treatable.
And so they're taking out the whole prostate. And
Yes,
your goal is to irradiate the whole prostate for either
correct.
one. So, you're saying that you can get inflammation in the bladder because you're hitting other areas. Are they more
Yeah.
focused in how they do radiation? Does that
They do.
change
They have
things?
everything from where they put these, what they call them seeds, these radioactive pieces of radioactive material into the prostate that delivers the radiation more localized so that there's less bladder exposure. But at the end of the day, the prostate lives between the bladder and the rectum, and both the rectum and the bladder can be affected by the radiation. But I mean, but it is an effective form of treatment for some patients.
Are they doing most of the prostatectomies now robotic or laparoscopically? Because less open,
Yeah,
and then it's
they
all.
are. So, in my old days, we did them open. They've now moved mostly to robots,
Mm.
but they're still taking out the prostate.
And it talked about like I think almost 98% or if not all are done robotically
Yeah,
with
yeah.
very few failure rates, right? During versus, a laparoscopic appendectomy, might have some failure rates and you have to do an open. It's very unlikely.
It's unlikely. I mean, most training programs, the guys still learn how to do things open. If they need to get in there and open it up, but the robot now is so daggone good.
I mean, your vision's so much better through it. You have so many hands, right? And
Yeah,
we only have
yeah,
two
you're
other ones.
right
Yeah.
there. I mean, the anastomoses to connect the urethra back to the bladder is so much easier because you can see it.
And so the incontinence rate in ED, like incidence of that after. So if we were to talk about incontinence and a man being dry after surgery or radiation, let's just talk about surgery, specifically.
All right, so this is what I would tell guys. I go, look, I can tell you the stats and tell you you've got this percentage of erectile dysfunction that's possible, but stats are great for a herd, but not the individual cow. So let's just talk to the person. I'm pretending like I'm talking to the patient. I go, so I'm going to show you or tell you what we can do for erectile dysfunction if it happens, because the percentage is immaterial. It's 100% if it happens to you. I mean, so what difference does it make if it's only a 10%, possibility? And then that's where I would take the younger guy when I was in practice and I go, I'm going to show you the worst erection you're ever going to have. And I would introduce him to, a method that we can talk about either now or later that will produce an erection after a prostate cancer surgery or a radiology or, radiation treatment that will work.
So we can talk about those couple different options, the injectable and surgical options, because they need to know. You're right. It's 100%. That's a great point, as you always make in your, special kind of ways. For sure, I love your stories
You want to
and
hear a real
analogy.
story?
Yeah. Yes.
So one day I'll show him this is a young guy. He's probably like 38, maybe 42. And I was telling him that, we're going to do, I recommended surgery because of his age. And if he was going to be left in impotent, I had a treatment for him and I can show him what I was going to do. And while I was examining, I asked him, he said, "Do you want me to show you?" He goes, "Sure." So while I was examining him, I was really faking him out. And so during that exam, I injected his penis with what we call trimix, which is a recipe of different vasodilators. But I was examining him and I pinched him such that he was distracted, so he didn't even feel the shot. And then after that was all done, I said, "Well, I'm going to be back in about 20 minutes to see if that treatment worked." And he said, "What are you talking about?" I said, "Well, while I was examining you, I gave you that treatment for erections just to show you the worst erection that you're ever going to have if you're not able to do it on your own." He said, "What did you do?" I said, "Well, I gave you a little shot." He goes, "Where?" I go, "Where there?" He goes, "There?" I go, "Yeah, I did it there." And then walked out to see another patient while it had its effect. Walked back in about 15 minutes later, and the room was empty. And remember, I'd always would ask these patients to bring their wives with them because men don't remember anything. And because it was a cancer treatment, discussion, I
Yeah.
wanted the wife there.
Lots of facts.
Yeah,
Time to
yeah,
ask the
yeah.
questions.
And the
Yes.
room was empty. So I asked my receptionist, I said, "What happened to Mr. and Miss Jones?" And she goes, "They left. They said they left something out at the car in the parking lot. They'd be back in about 20 minutes." Because he'd got the best erection he'd had in about 20 years, and they had some business that they needed to go talk about, and then they showed back up later. True story. So that's what I'll do to show guys this is the worst thing that you're going to have. And look how good this worst thing is.
Yes. No, I do believe you 100% on that one. It absolutely does not surprise me. And that's great. Though, but that's what they need. Like, especially they, and everyone needs to hear that. So we're not going to edit that out by any means. No.
I mean, and then incontinence. That's much more rare than people realize. At the worst, you can put in a artificial urinary sphincter. And if your insurance is paying for your prostate cancer treatment, whether it's radiation or surgery, but I'll just tell you this, radiation makes it much harder to do because of the surgical planes are destroyed with radiation. But long story short, insurance will pay for an artificial sphincter. And then there's something, this is so simple. It's a $30 device called a Cunningham clamp. And it literally clamps the pecker. And then when they want to go pee, they release the clamp and they pee, and they just clamp it back. And the way it's designed, it doesn't hurt. So you can literally treat both of those issues, erectile dysfunction and incontinence, both with non-surgical treatments, or you can treat the incontinence with a little bit of surgical treatment.
And so obviously your incidence, like you said, it varies obviously, and it's 100% if it happens to you. But even then, it depends on age and medical conditions. And honestly, that can happen independent of having prostate surgery. And so, you're looking at those same end treatments.
Yeah. I mean, there's a lot of men as they get older have erectile dysfunction and have incontinence and no cancer. And the biggest thing I would always tell these guys is, look, if you're dead, you're not having sex anyway. I mean, so yeah, let's keep you alive.
When we talk about the regenerative treatments after, and somebody comes in, because obviously your risk, or at least the incidence or the severity of ED or even incontinence is going to be higher right after surgery, but again, resolves, or can resolve. And so once it's resolved, and we're talking about regenerative, acoustic shock wave, you know what I'm talking about, or injectable PRP, do you have like a baseline for at least trying to see if there's a change?
Always.
Yes.
I mean, I'm glad you brought that up, because remember, if I was talking about the worst thing, which were these injections for the trimix, the idea is for them not to use it. And we see so much improvement with regenerative therapies. The platelet-rich plasma, Priapus shot treatments where we inject the patient's own platelets. There are some other growth factors that we can also inject that we can talk to the patient about. The acoustic wave treatment is huge. So all of these guys are candidates. And the whole goal is not to have to do the vasodilator injections. And many of these guys are able to achieve erections based on these other types of treatments that you and I do every day.
Yeah. And I think that, as they get older, and I tell men, if it's like, well, how long does it or, what's the guarantee on any of it? I'm like, well, there's a guarantee everything's going to get worse when you don't have a prostate surgery and you have ED. That if you don't do anything, there's definitely a guarantee it'll get worse. That's the one guarantee. And the end result is what you're talking about, injections, and so it's worth trying. And again, we invest so much time in our house, our car, our yards.
They're like going, the insurance don't pay. I go, listen, we're talking about, your equipment. More than likely, the kids are going to inherit more than they deserve. Spend it on yourself. I mean, this is your function, and there's no risk other than a bruise.
Correct.
I mean, it's your own platelets that we're pushing back in.
And we spend we yearly upkeep the yard, the house. If we didn't do anything until we were 70, or we didn't do any house upkeep until 70 years old, like the house is 7 years old, there's a lot of upkeep we're going to have to do, right? And so it's just part of it. We didn't know.
Yeah. I mean, if your tire's flat, you're not going to just say, well, I can't drive anymore. I mean, you're going to fix that. And you think that tire is going to last forever? No.
So I talked to them about, and I don't know if maybe you and I had talked this line before, but I always say, again, insurance stuff is like a leased car. We lease a car because we don't want any of the major expenses, right? So we lease it, but it still doesn't cover the things that you need upkeep on that happens. So brakes, tires, you're still paying for it. Everyone needs it and they do it and we pay for it. And
Yeah.
insurance is the same thing. You know, it's the major stuff that's covered, anything that makes a difference. And, you know, again, it's an upkeep and they know people are going to need to do it to get that function. And so it's not usually covered. It's like the least covered items or not covered items. So
Now I will say this. I do think it's important that guys, if they go down this path and they do end up seeing one of us and go through these regenerative treatments, to understand that if they do have prostate cancer and they've been treated, that's considered a complicated treatment. And so there's no way, and I tell a prostate cancer patient, if they're doing acoustic waves, they're going to be set up for at least a minimum of 12 treatments. If they're doing a prophet shot with the platelet-rich plasma, they're going to do two within 3 months.
okay.
The idea of just doing one, they need to do, they are not the typical guy that's showing up with ED or incontinence. They've got a complicated issue.
And they have to start at a really decent level. No, and
Yeah,
I always say six packs or P shots. So you at least recommend the 12, Gainswave and 2 P shots. And I think that's reasonable. So, and we approach it the same way. I wanted to get your input. I know we've talked about it, but there's so many men asking questions about, prostate cancer and the incidence of ED. So hearing you talk just so blatantly, openly, and transparently about it, I agree with you because I didn't even realize that the screening wasn't standardized. I thought it was.
So what I hope the patients or the people watching this will take home is ask their primary care provider to say, I'd like to have a rectal exam yearly, and I'd like to have a PSA. And I'd like to have the PSA done before the rectal exam because the rectal exam can artificially inflate the PSA value. But you need to have a PSA no differently than a woman's going to have a breast exam. I mean, what woman goes to her yearly physical and doesn't have a breast exam? But the prostate is being neglected from a DRE and a PSA screening is beyond me. They need to treat it like breast cancer because as I read the stats from the National Cancer Institute, they're identical. They're the same thing.
And further, patients can actually home screen where men aren't going to be able to home screen adequately with the prostate.
You can't do it.
No. So, well, definitely, I want to hear your experience with your doctors, with the diagnosis, with questions you might have. And obviously, Dr. Ibrahim is awesome at answering questions. So leave your comments, experiences, share. Please share this one. It's a huge topic. And so share this with everyone that you know that has had, and well, share it with all men because they need to know.
And I've got to put my plug in,
Yes.
Biltmore Restorative, medicine and aesthetics here in Asheville and now Greenville, South Carolina.
So, and again, we didn't mention that at the beginning, but we'll also put a link in the description. And George and I work together across the mountain from each other. We just are in touch all the time, but we have separate practices across the mountain range from each other. And he has an excellent practice. And again, he is available. And you guys can reach out to him. You'll have a link and then you'll have our link. And if you have questions, experience, please share this with everyone, all men and all families. And let us know if you want to hear anything else, because we're willing to deep dive into anything men's health and again all things wellness and sexual wellness.